Okay, so thank you very much for joining us this afternoon. I'm Christina Matra from the University of Sheffield, and I'll be one of the chairs for the session.
I'm Sandra Bontrick, I'm one of the Spinal Fellows from London. I'll be co-chairing with Christine.
And can we just remind people, if you've got questions, do come forward to the microphones. Even if you think you've got a loud voice, we can't hear you if you don't come to the microphones. And please do introduce yourselves as well before asking the question. And finally, please do keep it to questions, not statements of fact or trying to big yourself up. Do stick to asking the presenters questions, please. Okay, so it's my pleasure to invite the first speaker, Elie Najjar, who's going to talk about human versus machine, deciding on high-stakes surgery in possible cauda equina syndrome.
How will I be able to scroll? Do I have a clicker?
Yeah, what's up?
Can I use the clicker?
Oh, sorry, I didn't realize it wasn't there.
So, good afternoon, everyone. My name is Elie Najjar. I'm a spinal surgeon from Queen's Medical Center, Nottingham University Hospital. And it's a pleasure to be here today because I will be discussing an increasingly relevant question in modern medicine. Can artificial intelligence play a role in high-stake decisions, such as cases of cauda equina syndrome? We declare no conflict of interest. We all know that cauda equina syndrome might seem straightforward, but it's always challenging. Okay, despite using GIRF guidelines, despite abiding to MDT decisions and discussions, sometimes it's not straightforward. So would artificial intelligence, and in particular the model we used was ChatGPT, can it assist in real-world decisions for high-stakes surgeries such as cases of cauda equina syndrome? To answer this question, we collected around 160 cases who presented to us in our tertiary referral center for suspected cauda equina syndrome. We transformed those referrals into PowerPoint slides, and then to decide on the number, we did a power analysis that required 51 cases, so our numbers are multiplied by 3, which strengthens our methodology. And we ran those cases by the spinal MDT, asking whether urgent surgery is indicated for those cases or not. Now, when it was time to compare it with artificial intelligence, we anonymized the slides, and we used 10 slides to calibrate ChatGPT after uploading the GIRF guidelines to make sure that it's guideline-based, the decision is guideline-based. This is an example of a slide that we updated to ChatGPT. It includes the age, demographics, current complaints, past medical history, clinical examination, including DRE and bladder scan. And for the imaging, we uploaded the radiological report. And calibration was to introduce ChatGPT to our boxes and abbreviations to make sure that he understands it. And after doing the 10 calibrated cases, we simply uploaded each case to ChatGPT, asking him, is this cauda equina? Do we need to operate urgently or not? We were surprised to find that around 90% of the time, ChatGPT and spinal MDT came up with the same decision. And 37% of the times, the decision was for urgent surgery. To do some statistics, the Cohen's kappa was 0.76, showing substantial agreement with a p-value of 0.001. Out of the 17 discordant cases, in 10 cases, ChatGPT recommended surgery, and in 7 cases, MDT recommended surgery. To take it a step further, we did a secondary analysis. We took those 17 cases, anonymized them again, and then ran it by 3 independent expert surgeons with experience of more than 5 years in spine surgery. And they were completely blinded to the MDT and ChatGPT decision. And we asked them, should we operate urgently or not? And we were surprised to find that only 64% of the time there was consensus between those surgeons. There's a lot of ambiguity here. Out of those 64% concordance, 73% aligned with the MDT versus 27% with ChatGPT. Sub-analysis showed some tendency towards surgical intervention with ChatGPT, but it wasn't statistically significant. The p-value for McNemar's test was 0.4. When we tried to analyze why would we have different decisions on something like Coda-Equina syndrome, we found 3 common patterns. The first pattern was differences in MRI interpretations. For ChatGPT, he seems to be dismissing cases where the report mentions moderate stenosis or lateral recess compression, and he seems to act immediately on wording such as crowding of the Coda-Equina nerves, while dismissing the rest of the scenario. Where for the spinal MDT, they took the whole picture into consideration, and they didn't care if it was chronic, if it was extremely cyanotic, if there wasn't new symptoms. There was also the factor of symptoms chronicity. MDT focused on change in symptoms, while ChatGPT focused on presence of red flags regardless of the timing. And finally, MDT seemed to sometimes prefer surgery to prevent incomplete Coda-Equina from deteriorating. Finally, of course, this is still a new topic. It is challenging. Yeah, mainly, we need to focus to prevent biases and who's accountable in cases where ChatGPT takes a decision. And finally, we need to maintain patient autonomy and informed consent. Thank you.
Thank you. Open to questions.
Thank you. Abrajo Bulash from Preston. It's an extension of what we heard in the morning about the use of the AI. And I think if you had the opportunity to put the image rather than the report through the AI, perhaps you would get a different outcome.
That's true. There are artificial intelligence modules that do read images. There are some reports comparing them to human radiographers. We still don't have access to this in our unit, and it's still a work in progress, right?
Thank you.
Noting that ChatGPT can read an MRI if you put the cuts. He analyzes, he knows which segment, he knows the level of stenosis and all of that.
Neil Oxborough from Manchester. 2 things. Yeah, first of all, I agree with what I was going to say is MRI reports are useless unless they show no Coda-Equina compression because they over-report things for safety. They just say always mild Coda-Equina compression. It means nothing. And secondly, the other thing that really irritates me that I think would confuse this is that every patient with any urinary symptoms seems to get an MR scan these days, and nobody takes a proper history. So unless you've got a proper history of whether it's sensate or insensate of what the urinary problems actually are, I don't see how you'll have nonsense going into your AI and nonsense coming out.
True. Just to clarify, this is all based on GIRFT guidelines. Okay, the urinary symptoms are part of the GIRFT guidelines. It's not the only part of it.
No, but I always say to registrars that if you went to a urology clinic and applied guidelines, you'd probably MR everybody in the urology clinic. We don't do that, so there needs to be some discrimination in the urinary symptoms, and we don't get any history.
This is why it is Coda-Equina diagnosis is challenging. Okay.
So for the sake of time, we'll move on to the next speaker, which is actually the same speaker, who's now going to talk about human versus machine, concordance and conflict in spinal oncology management.
Right, this time I won't elaborate a lot. We use the same concept, but the question now was those patients with metastasis, when should we operate urgently and when not? All right. So we applied the same methodology, but it was for a different cohort of patients, and the question was now related to metastatic cord compression, which we thought might be more complicated because of the variety of the presentations. We know that spinal metastasis is common, up to 70%. 5 to 14% will present with metastatic cord compression. and usually they do require multidisciplinary approach. So the current management now is based on the NOMS framework, where SINS is part of the mechanical stability to assess mechanical stability. And we wanted to know, would AI enhance decision-making in situations that requires multiple subspecialties? Again, we evaluated for the concordance between ChatGPT and MDT. We did the same, but on 100 cases. Also, our power analysis required 50, so we doubled it to increase the value of our study. We calibrated it with 10 cases. This time the information were more. We included Karnofsky. When we had it, we included life expectancy, SIN scores, calcium levels, past medical history, oncology plan, if present, and of course the radiology reports. Okay, so we ended up with 100 cases. The most common tumor was lung, followed by breast and prostate, then tumor of unknown origin. And we had 86% concordance between ChatGPT and the MDT. And Cohen's kappa was also significant with 0.66. 26% of the time, the recommendation was for surgery. When we tried to subanalyze the discordant cases, we found out that they were slightly younger, predominantly males, and the most common tumor was tumor of unknown origin. Why did we have the discordance? We also searched for patterns. We found out that ChatGPT, out of the whole NOMS thing, he focused on stability, and it immediately recommended surgery, while for our spinal MDT, they focused more on the systemic problems with the patient, thinking that actually if I'm going to operate on him, but he's not well enough to live enough to survive the surgery, I'm going to go for palliative. So there seems to be a difference of focus on parts of the NOMS criteria. But again, McNemara's test did not show significant directional bias when comparing whether either one prefers surgery or not. So again, we do have substantial alignment. We do have discordance, probably because AI prioritizes localized factors while MDT still integrates the whole image and puts it into perspective. But still, an 86% is a promising number. We're not talking about AI replacing humans here. We're talking about AI acting as a support and probably as a triage machine to make things quicker. Okay, we're not at the level where AI can impose human, and this study does not support that yet. Of course, again, it's a work in progress. There's the ethical issues, there's the bias issues, but it is a very good starting point. And again, this is the first study to discuss such a topic in such a methodology. Thank you.
Thanks very much for your excellent talk. I'm Sam Vimlachandra from Birmingham, QA. I was interested in asking, have you gone in to look at the ones ChatGPT said operate or don't operate,
yeah,
and whether they were the same cases as the MDT said operate or don't operate?
Yes, of course. So when we talk about concordance, we're talking about concordance on about the same case. So it's not about 30%, but there are various patients. We're talking same patient, same decision for the same patient.
So the decisions were the same between the two.
Yeah.
Yeah. Thank you.
And that's a very important point, yeah, or else all the statistics would be completely off.
Hi, I'll start with, it's great that someone's looking at, we've heard this morning, this is important, but is this really the right direction of travel? Because when I decide to operate on someone, I talk to them, I phone their oncologists, I ask what they're like, I ask about how they view risk, I watch their face as I talk to them, I watch their family. I don't just make a decision on an algorithm, I look at lots of things about the people who've treated them, the patient, their relatives, and all of that filters into my decision. And this is probably never, ever, ever going to do that. And I think, and secondly, that this raises really important philosophical questions about what is the role of a surgeon. Because if the role of a surgeon is just to execute that a machine, execute maybe the wrong word, perform something that a machine decides, we are just glorified technicians. Because actually, why do most of us become spinal surgeons? Because we like the challenge of complex decision making and the responsibility for those decisions as well. So I think there's some really, if you think this is the direction of travel, there's some really important philosophical questions to address. But do you think it's the direction of travel?
What are you discussing, Coda-Equina syndrome or oncology?
Well, I think both, because again, Coda-Equina is the same, that you don't just say these are the symptoms and that's the scan. You then talk to the patient.
So in tertiary centers, we usually get the information on refer a patient, right? You don't see this patient. Someone in Leicester will see my patient, tell me this is the examination, take a decision, should I blue light the patient, okay?
I suppose the ones where it's barn door, yes, you don't see them, but there are many where it's nuanced, and the first thing we say is, I want to meet the patient and talk to them.
Yeah, absolutely. But the decision to bring them over for surgery is not based on a face-to-face meeting with this patient.
Yep.
And in no way we are saying that ChatGPT is taking the decision here as in, now I'm taking him to theater. What I'm saying is that ChatGPT can help as in triaging those patients and in supporting decisions, especially from people who cannot take those decisions, all right? I'm not talking about going to ChatGPT, and this is why I said it's not replacing human value. It's just a way to make things quicker, easier, triaging safely until we get the chance to take the decision through the MDT. We don't have a gold standard here, by the way. Yeah.
Sorry, we are over time, so we're going to have to move on, but please do use the coffee breaks to discuss further. Thank you. Okay, so next up we have Ruth Wilcox, who's going to talk about in vivo safety study of an injectable hydrogel for nucleus augmentation in an aging sheep model.
Thanks, Christine. Thank you for the invitation to talk today. So I'm Ruth Wilcox. I'm from the University of Leeds, and this study is a collaboration between the Universities of Leeds and Nottingham, also with collaborators from the Royal Veterinary College and Leeds Teaching Hospitals Trust. So nucleus augmentation or replacement is becoming an emerging potential treatment, early stage treatment for intervertebral disc degeneration. The first generation of products that reached clinical trial, perhaps about a decade ago, experienced a number of complications, including expulsion back through the hole by which the materials were injected, and subsidence as well, because there was a mismatch of properties between the material that was injected and the surrounding tissue. So really the aim of nucleus augmentation is to try and at least prevent further disc height loss and restore some of the biomechanics. We've been working at Leeds for actually also over a decade on a particular type of hydrogel, which is a self-assembling peptide mixed with the glycosaminoglycan, as a potential treatment for, or as a potential material for nucleus augmentation treatments. My colleague James Swarren is about to present more of the in vitro studies and more on the material itself in the other session just after this. But basically the material has been designed particularly with nucleus augmentation in mind. It can be injectable down a very narrow gauge needle to prevent damage to the annulus and expulsion. It has a match with the native properties of the nucleus tissue, and it mimics the action of the healthy nucleus by drawing in water due to the glycosaminoglycan content. So here I'm going to report on our first in vivo study. And we're challenged here because there's no established models for these types of treatments in a large animal model. There's some potential to use young animals, but then that requires an artificial degeneration stage. And we'd recently shown that elderly sheep exhibits degeneration that's similar to human intervertebral disc and facet joint degeneration. And so the aim of this study was to establish the safety of our peptide GAG hydrogels in nucleus augmentation using an in vivo aging sheep model. So the study was performed at the University of Nottingham in their large animal facility. We used sheep that were greater than 6 years of age. They were initially CT imaged, and then we put on adapted Fitbits so that we could monitor those sheep in the field for 3 months prior to treatment. We then performed the nucleus augmentation procedure. In each sheep, it was performed in 3 lumbar intervertebral discs, and we had 3 sheep that we injected the peptide in, and also an additional sheep that we injected the saline sham into. The procedure was undertaken with the sheep anaesthetized, and we used fluoroscopic guidance to guide the needles. And we had a custom delivery system where the peptide and GAG were injected simultaneously down very narrow gauge, 29 gauge needles. We then monitored the sheep for a further 3 months before they were euthanized, and then we performed ex vivo analysis by MRIing both the treated and the adjacent levels, and also performing histology. So onto the results. Post-operatively, we observed no adverse effects following the hydrogel augmentation, and the sheep returned to normal levels of activity. From the ex vivo analysis, the histology showed no signs of inflammation or other adverse effects. And from the 3D imaging, the MR and CT, we saw no difference in disc height pre-surgery to post-mortem in either the treated or the non-treated intervertebral discs. So, in conclusion, this study's really been around demonstrating the feasibility and safety in a large animal model, and the in vivo study showed no adverse effects from the peptide GAG hydrogel injection. It was quite challenging, particularly with the aging sheep model. The disc spaces are exceedingly narrow. We had challenges in locating the needle even under fluoroscopic guidance. And the modalities of imaging that we used limited our ability to detect or have a resolution that was sufficient to detect kind of small changes in disc height. We're now going back into the laboratory to undertake an in vitro study on degenerative cadaveric tissue. Yeah, just wrapping up, which we hope then we can do some of these more kind of high resolution imaging on and understand a little bit more about the biomechanics of that restoration. Just like to acknowledge the co-authors and the funders, and we really value particularly clinical opinions on where we're going next with this study. So we have a stand in the exhibition hall. Please do come and visit us. We'd love to have a chat. Thank you.
Any questions from the audience?
Yeah, so really interesting work, Ruth. I was just wondering, what volume did you inject into the sheep?
It was about 0.5 millilitres. They're quite small disc spaces, and certainly that's something in our in vitro studies in the lab. We've been trying to optimise the volume to inject. For human discs, certainly that would be larger, and we're hoping that with our next cadaveric study we can really start to investigate the relationships between volume, height restoration, and the progression over time as well.
Did you manage to inject the same volume to every level that you...
Yes, we did, and again that perhaps indicates that we could have gone a bit higher actually, because we didn't get to a sort of a limit on the volume that we could have injected.
The last question from me is, how did you decide which discs you're going to inject? Have you standardized the same discs in every sheep, or have you identified the ones that are degenerate?
Yeah, the imaging showed that there were sort of general levels of disc height reduction across all of the discs. So we took out any sheep that had sort of very obvious osteophytes and so on. We tried to do the same 3 levels in each. In one of them we had to move things down a level just because of the surgery and where the vet could actually get the needles in.
Okay. Yeah. Thank you.
Thank you. Did you have one last question. Did you have a control as well, or was it just purely the injection?
So we kind of had the controls of the adjacent levels within the sheep. And then I said we had the sham control as well, so I did present some results there. We didn't see any changes in the disc height in the sham either, but as I said, the resolution wasn't really good enough to see those subtle changes in height.
Thank you. Thank you.
Okay, so next up we have Zizi Zhang, who's going to talk about real-time tissue segmentation and surgical tool detection in endoscopic spinal surgery.
Good afternoon, everyone. I'm Ziqi Zhang, who present for the research topic real-time tissue segmentation and surgical tool detection in endoscopic spinal surgery. So the endoscopic spinal surgery is a minimum invasive surgical technique which can be used for 75% of spinal condition. It causes minimally in blood loss and tissue damage. It's widely adopted in the Western. It starts to be used in other regions of areas. So for its adoption, it faces some challenges. Firstly, it requires clinicians to have special development on hand-eye coordination. Secondly, it requires clinicians to have different understanding on different autonomy, because using different approaches. Finally, there are few endoscopy centers in the UK, so there are few opportunities to receive training. We are inspired by the progress of modern computer vision technique. Computer vision is a technique which allows computer to see and interpret image and other format of data. For example, machine learning engineers have used MRI scan to detect the appearance of tumor. So we have created an application to successfully detect location of different types of tissue and surgical tool. So here is our workflow. We collect data from actually internal endoscopy video. We cut video into different frames, and we allow our specialized medical students to label the data. And then we pre-process the data. We change the format of data to machine learning algorithm can understand. And then we train the models on our server, and then we deploy model on different devices to test its performance. Finally, we evaluate the different sessions and to see which session should be improved. About our dataset, as I mentioned, our surgery video is an internal endoscopy surgical video. And there are around 1,000 labeled images. We choose it carefully. We remove all the blurring and unclear images. Are labeled by our medical students. And we labeled different tissue classes, ligament, disc, bone, epidural fat, and regular fat. For the surgical tool, we labeled working channel, radio frequency probe, straight scissor, straight roller, and angle rollers. For the object detection model, we use Euro V8. We use a pre-trained Euro V8 on COCO dataset. It's very cutting edge, and it's generally used in industrialization, such as quantity checking. It can run in real speed on a normal laptop. The model correctly identifies 98.2 of relevant frames of radio frequency probe in a surgery video. And for segmentation model, we use UNet. UNet is also a state-of-the-art architecture which generally used in medical imaging. And on the right-hand side are the results of the segmentation. The mean intersection over union can be 59.4 now. So I think that's all for my presentation. For next step, we are going to enlarge the data set and try with the more complex model. Thanks for all the medical students, and thanks for Institution of Healthcare Engineer of UCL, and thanks for support of Dr. David Baxter. So if you are interested with our research project, please contact with me or Dr. David Baxter. Thank you.
Any questions from the audience, please? We have one question. You said you had 1,000 images that you applied to the, you were given to the students. How did you choose which images to give to the students? Were they from one operation or were they from one video?
From one operation, actually.
From one video?
Yeah.
Okay. And the second one is, what applications does this have to clinical practice?
So it can reduce the training curve because actually it segments the different tissues, and also it can detect the different types of surgical tools, so it will reduce the learning curve for the new surgeon.
So predominantly educational purposes
Yes.
it would have. Okay, thank you.
Thank you.
Okay, so the next speaker is Chan Hee Ko, sorry if I pronounced that wrong, who's going to talk about high-volume, high-fidelity surgical simulations for overcoming the learning curve of endoscopic spine surgery.
Hi. You can call me Austin. I've got two names just to confuse you. But I'm a neurosurgical trainee, currently doing a PhD. And this talk, I'll be talking about overcoming the learning curve of spinal endoscopy with high-volume, high-fidelity surgical simulations. So just a bit of a background for those of you who are not so familiar with spinal endoscopy. Broadly, you can think, it breaks down into two techniques. There's the uniportal, doesn't have a laser. There's a uniportal technique where your instruments and camera go through the same cut and through the same tract, and there's biportal technique where you have separate tracks for your camera and instruments. For the purposes of this talk, we'll be sticking to uniportal techniques, which then you can do transforaminal or interlaminar approach. So the motivation, our previous speaker touched upon this, but the motivation really is that spinal endoscopy is something that can be very difficult to pick up. It has a steep learning curve. And particularly if you're already a spinal surgeon who's accomplished and have performs the traditional kind of open or microscopic techniques well, this can be a step back with all the implications on surgical efficiency and speed and safety, et cetera, et cetera. What's on the slide is just the results of a meta-analysis that we did, which shows on average you need to allow about 60 cases to overcome most of the learning curve. That's on average. If you want the vast majority, 90%, to have overcome the learning curve, you probably need to allow 70 cases. The previous was for transforaminal, this is for interlaminar. Numbers are very similar. There'll be variations kind of within those numbers as well, but that's the kind of general message. So coming back to the motivations for high volume simulations, if instead of going on cadaver courses or simulation courses just once or twice in a year, which even if high quality might not give you the frequency that you want, or instead of overcoming the learning curve within a real world environment and all the stress that it brings, can you overcome at least a part of the learning curve with high fidelity simulations and doing these in high volumes? So the methods, this is still a kind of in progress study presenting the interim results. But the methods are very simple. We've got 11 consultant spinal surgeons recruited to date. The plan is for each to complete about 10 simulations each. We've got, at the time of submitting this abstract, we had 23 simulations conducted. The task is very simple. We provide a high-fidelity simulator along with a high-fidelity simulated X-ray system, X-ray free, but it gives you the images you need for spinal endoscopy. And the task is just to complete a simulated endoscopic discectomy. The data collection, we collect various metrics of performance like operating time, complications, et cetera, et cetera. The part of the study we haven't yet made so much progress on is collecting the real-world data following these surgeons up. And the analysis is just a comparison to the baseline that's been established in the literature. For those of you who've not seen the real spine, I suspect a lot of you have. This is You can see the X-ray on the bottom left. You can see the anatomy on the right, and this is the setup that we have. So the results, as I said, the results will be within the simulation environment itself in comparison to real-world environment. But you can see the expected time of the very first case you do within simulations we found was shorter, much shorter than in real life. But and that makes sense. It probably reflects a mixture of being in a safe environment, fairly risk-free, no real patients, being braver, maybe a bit more kind of careless as well. But what's really interesting is that learning rate in the simulated environments is much faster than in real life. This is with operating time. With complications, very similar. The incompletion rate, or the rate at which they abandoned the simulation for whatever reason, we don't have the data for real world, but that's the data there for simulation, just for interest. So conclusions, it's very difficult to draw firm conclusions on these incomplete study. But I think it's fair to say that high volume, high fidelity simulations can probably provide a safe environment to overcome at least a part of the early learning curve. And there are hints that high volume simulations might accelerate, at least within this very specific environment we provide. The simulation might accelerate the attainment towards the journey towards proficiency. As I said, what we want to do more simulations, but what we also want to do is to follow up the surgeons taking up spinal endoscopy to see how it translates into real world.
Finish off.
Yeah, so that was my very last sentence. If any of you are interested and spend significant amounts of time in London, please do drop me an email or speak to me afterwards.
Thank you. Thank you. May we invite questions from audience?
Hi. I suspect your simulator's going to work, is my hunch. But the missing bit, the last systematic review on surgical simulation I looked at, less than 1% of studies publish anything on cost effectiveness. And the key challenge, if I employ your surgeons and they say, I can go on this simulator, I'm going to say, that's great. But I might say, but you can do it in your own time because I'm not paying you to not treat patients. So do you have plans to look at cost effectiveness and whether this is deployable, employable, both, whether that's reducing complications, whether that's theatre productivity? There's lots of avenues to get there, but it feels like we need that data.
Yeah, absolutely. So cost effectiveness has comes lots of forms, complications. When we're thinking about training specifically, part of the motivation for doing a study like this is we want to extract quantitative data. So we want to quantitatively define what a learning curve looks like with kind of traditional methods of what's being published in the literature. However imperfect the kind of analyses may be, we want to quantify what this might look like, training with simulations might look like, and how it might compare to traditional methods. So traditional methods, you have your cadaveric studies, there's the implications on reduced efficiency in real-world cases. Did I mention cadaveric studies have their own costs? Yeah. So there's lots of things that go into it, but to do a effective cost effectiveness or economic analyses, for me at least, requires this work to quantify what the benefit or the difference is. But that's a very good question, and it is a important question, I think.
You can nod or shake your head somewhere, but do the participants get any feedback between cases of any sort?
Feedback in the sense of...
So when you do a case on this, does someone say, here's what you need to work on for next time, or do they just do it and there's no feedback at all?
Not so much. Part of the problem... I mean, you get feedback during the simulation, but...
No, fine.
Yeah.
Okay, so actually, so I know there was someone else wanted a question, but it's the same speaker, so you can always ask it on the next talk if you want to as well. I don't know if my thing's still working. So, and the final talk within this session is China again, who's going to talk about sensorized surgical force gloves and machine learning for the classification of proficiency in spinal surgery, a preclinical study in high-fidelity lumbar decompressions.
Right. So for this second talk, I want to pivot away from talking about the process of training to thinking about how we measure and classify surgical skill and surgical proficiency. For this study specifically, it's about we apply a novel technology to measure surgical forces and work on the data that we get from that. Just to start off this talk, I want just to yourselves, if you think about what qualities make a good surgeon and how we might go about measuring these qualities, how we do it now and how we would do it in an ideal world. I'll talk about it in reverse order. How I broadly think about measuring surgical metrics is you can get your subjective metrics and objective metrics. And you can assess qualitatively or quantitatively. All of these have their roles, but what quantitative measures of surgical metrics allow us to do is to do something like this, where we plot the relationship between the surgical metric and your likelihood of being an expert or where you are on that journey towards surgical proficiency. And it also allows us to set a quantitative threshold and an objective threshold of what surgical expertise might look like. This study, this is from a recently published study where we looked at operating time and OSATs, which is a subjective but structured quantitative assessment of global kind of surgical performance. I'll be talking about this a bit later on. What qualities make a good surgeon? I just listed the first few that came to my head before I got to the meat, which is surgical forces. Surgical forces is something that's traditionally very difficult to measure, often relies on a visual assessment by the surgical supervisor of how the trainee or the supervisee is doing with their tissue handling. But it's difficult to measure in an objective way. So for this study, we utilized our nano-engineering colleagues at UCL developed these piezoresistive force sensors that we mounted onto surgical gloves that allow us to measure the force being applied through the hands to the surgical instruments. We had 30 surgeons wearing these gloves undertaking a simulated open unilateral lumbar decompression. And we collected and recorded, saved the force recordings there. And these are what the force readings look like. Just two representative examples. On the left is expert, on the right is a novice. And it's very difficult to tell, at least to my naked eyes and to my brain, or whatever there is of it, which one, what it is about these that makes one usage of force, expert versus novice. We tried looking at average, the mean force, the median force, the range, variability, et cetera, et cetera. None of these kind of simple metrics did the job in terms of classifying surgical skill. But we still postulated there must be a complex relationship between the force recordings we're getting and your kind of level of surgical proficiency. So we then turned to AI. We utilized a hybrid AI design of convolutional neural networks and transformer networks. They took crude segments of force readings as their input and outputted the prediction and the likelihood of someone being an expert versus a novice surgeon in these lumbar decompressions. And we evaluated using cross-validation, balanced group cross-validations. So the results, again, this is kind of in progress, it's getting there, but I think there's a few more kind of percentage points that we can eke out. But the best result we have so far is 84.3% classification accuracy, which is reasonable in my mind. And it's comparable or even compares favorably to the previous studies we did with operating time and these quantitative global assessments called OSATs. Receiver operating characteristics. For those of you who are not so familiar with ROC, the principle is there's always a trade-off between sensitivity and specificity, but plotting this curve allows us to visualize the discriminative index across the range of thresholds. And you can get a nice, neat single number by looking at the area under the curve. So the area under the curve for these AI algorithms on force readings was 0.9, which is, thresholds are arbitrary, but most people would say that's good or very good.
Sum up,
Oh, I'll be very quick, yeah. And it's all kind of comparable. The biggest problem with AI algorithms is a black box. So it can tell me if I'm good, it can tell me if I'm rubbish, but it can't tell me necessarily why or what I need to do to change. And that's really the direction that we want to start taking our work into, is to develop algorithms that can tell us how we can improve our usage of surgical forces. But this is a kind of big area, work to come in the years down the line.
Thank you.
Once again, very interesting techniques. But have you tried this in the so-called experts, and what's the variability of the forces between the experts?
Yeah, so we had 8 expert surgeons. Some of them were consultants, some of these were post-CCT fellows that we grouped under this. There was significant variability in the force readings we were getting. Now, part of that was just because an artifact of how the force sensors are mounted or how they're being applied, which made the study even more difficult. But yes, significant variability within groups. And there must be, the AI is telling us it can predict with reasonable accuracy between groups. So the real challenge here is trying to predict, trying to gain some insight into how the forces might differ or change as you move from being a novice to an expert. But yeah, there will be significant variabilities within the use of force by the experts.
What is the hypothesis saying that the pressure relates to expertness?
That's right. The pressure, the force being applied from the hand through the sensor onto the instruments. We can use that data to classify experts and novices.
I didn't just wake up this morning and decide to be grumpy, I promise. This is cool and sexy, isn't it? It's really interesting. But I suppose there's a group in Edinburgh that you may or may not know looking at the non-technical skills in AI in operating theatres. And the question they keep coming back to is, how does their version of this, tie to the patient outcome? That saying that person uses more force, but if they get amazing patient outcomes and the top surgeon in the UK on the registry, it doesn't matter. So how do we link this to the patient outcome and define a zone of safety, if you like, because that seems to be the obvious application of if someone can't get in within these parameters within a time frame, can we produce data that they may never be safe and we need to counsel them about other careers? Yeah,
absolutely. That's a very, very good question. And it's a question
Sorry for giving you a hard time.
Oh, no. It's I love thinking about these kind of things. Patient outcomes, in my mind, are the gold standard outcomes for any kind of surgical research, because ultimately it's about the patient and the difference that we make to patients. The difficulty with surgical research, and particularly with research in surgical training, is you need to be able to collect a certain volume of negative outcomes as well to be able to perform comparative analysis. When it comes to surgical training specifically, a lot of training surgeons, particularly surgeons like people like me, trainees, but even people taking up endoscopy for the first time, maybe proctored, have someone ready to take over. The problem becomes very difficult to collect the volume of negative outcomes that happen. So we do end up relying on surrogate markers that we've used for decades, even a century, of what makes a good surgeon. And these might be years of experience, what ST level, or whether you're a consultant or not. So we do rely on surrogate markers just to allow the research to move forward. If we're in a position to collect patient outcomes, that would be the absolute dream.
Thank you.
Thank you. Any other questions?
One last one.
It's just a very quick one. I think that's really interesting, but as well as the pressure, you could actually look at also the actual movements of the hand, for example, and having sort of the most leanest movements, if you like, in other words, reducing wastage. And I know there's been some research done on that, but that might be something interesting and maybe an add-on to what you're already doing.
Yeah, absolutely, absolutely.
Okay, so thank you very much.
Thank you.
And if we can thank all the speakers as well again for the session.
Right, so it's with great excitement that I introduce Professor Harbinder Sandhu, who's a professor of health psychology at the University of Warwick. And she's going to tell us about the last 10 years of her life working with opioid use. And I think as clinicians, this is a really, really exciting to understand what can we do differently and how can we manage this problem within the patient population we see. So thank you, Professor. Over to you.
Thank you. Can everybody hear me okay? Yes, that's great. So my name is Harbinder. I'm a professor of health psychology at Warwick Clinical Trials Unit. And my work is very much based around the design and testing of complex behaviour change interventions. So I'm really excited today and quite honoured to be here. This is my first BritSpine conference, so hopefully first of many to come. I'm enjoying it so far. So in terms of what I want to cover in this for the next half an hour or so is talk a little bit about the background of sort of where our understanding is at the moment for opioid tapering programs, take you through really the iWatch clinical trial. So that is the clinical trial that we've just published. And then talk, because it has been literally the last 10 years, we've learned a lot about opioid tapering, about the types of things that will help people and motivate them to consider tapering off their opioids, why they should actually consider tapering off their opioids. But I'm really interested in where do we go from here? And that's the kind of discussions that I would really appreciate to have today, but also for the rest of the conference as well. So a little bit about the background. So we know that 1/3 of chronic pain patients is prescribed an opioid medication. And in the UK, over the past decade or so, we've seen a 400% increase in the prescription of opioids. Now, I'm sure you've all heard or read papers and know that long-term use of opioid use causes severe complications for patients, including increased mortality. They have to live with a whole host of side effects, and we also know it increases dependency as well. So over the years, there's been especially the recent years, we've seen a bit of a push to try and reduce and help patients come off their opioids, especially, I guess, in terms of guidance. And we have seen between 2019 and 2023, so these are like the recent figures from NHS England, there has been a slight drop. So we've seen an 8% reduction, which equates to around 450,000 less prescriptions. Saving is predicted around 350 lives and 2,100 incidences of harm. But we have to be really careful here that we don't get too carried away, because it's great that we're starting to see a bit of a decrease in opioid prescribing, but we need to understand, first of all, how that is happening. Are patients being supported? Are they still involved in that shared decision-making process? And what's being offered instead? So, for example, we've already seen a slight increase in gabapentinoids being prescribed. So what we don't want to do is see one being reduced whilst the other one is being increased in terms of prescribing. The graph that is presented there just shows the geographical spread of opioid prescribing in the UK, in England, by CCG. And the darker areas, the red, the dark blue, shows higher prescribing rates. So we know that there are geographical differences, especially in the northeast. And we need to understand what those factors are and why. And there is some suggestion that it could be due to factors such as socioeconomic deprivation. There's higher rates of chronic the prevalence of chronic pain are higher in the northeast, and there isn't enough availability of other evidence-based programs to help people taper off. So we need to bear this all in mind when we are thinking about designing our interventions. So There are a few systematic reviews that have been published over the last few years, and we have to, again, in terms of interpretation, they do vary slightly. So I'm presenting a review by Avery that was done in 2022, and in their systematic review, the aims were to look at the effectiveness of interventions to reduce or discontinue long-term opioid treatment. And what they included in their final sort of meta-analysis was 11 randomized controlled trials. Now, for the purpose of this presentation, I want to particularly focus on sort of pain management, the behavioral type programs. In their review, if you are interested in finding out more about the other studies they included, they had pharmacological interventions, spinal cord stimulation, but very small studies. But in particular, like I said, the pain self-management is what we're interested in. And what that included was CBT, which is cognitive behavioral therapy approaches. So really helping, again, people to understand, accept around sort of their pain and pain management, and teach them self-management skills of pain, which includes educational components. And then also programs around including physical activity and outpatient programs. So generally, in the systematic review, so 2 studies were included when looking at opioid discontinuation. And you can see there that the interventions did actually favour the pain management programs. Now, we have to take this with a bit of, again, just a little bit of caution, because the quality of the studies were low and there was a high risk of bias. But what we are seeing here, there is an indication that the pain management type programs could be effective in helping people discontinue their opioid use. And then the other studies that were reported in that review were around opioid dose. And again, focusing around the pain management type interventions, you can see that they are favouring the intervention. But again, the studies were quite small, and we have to be careful how we interpret that data. So where does that lead us to at the moment? So in terms of guidance, the current NICE guidance just suggests that we really have to start talking to the patients first. That's where it begins. How do we start to bring up the conversation around opioids, discussing the risks and the benefits with them, and really going through the treatment plan? Now, I'm sure a lot of you are sitting in the audience thinking, well, that's great, because as a psychologist, I get an hour with my patients. But if you've got 5 minutes or 10 minutes, what are the key things that you want to really get across in that consultation? And I know Peter's doing a keynote after this around communication, particularly around back pain. So I think the consultation is a good starting point. But the guidance very much is around helping people weigh up the risks and benefits of opioid treatment, but very importantly, keeping them involved throughout the process in terms of shared decision making. Okay, so the iWatch trial. So this is the Improving the Wellbeing of Opioid-Treated Chronic Pain clinical trial that it was a study that was funded by the National Institute of Health and Care Research and has been published in JAMA 2 years ago in 2023. So I'm going to take you through very sort of briefly, I can get a bit carried away, so definitely tell me to stop if I talk too much about this. And then, so I'm going to talk you through what we did, the results, and more so around the implications. So it's a pragmatic multi-center controlled trial, and we wanted to test the effectiveness and cost-effectiveness of a multi-component self-management type program. So this is going to include all sort of the behavioral techniques, which I will go over a little bit more. In designing the intervention, we really did co-creation. So we worked with patient and public involvement. So we had various meetings to discuss what are the key components that are important when we're thinking about what's going to help them to make the decision to taper, and also what are their challenges and barriers. So the setting, so we ran the study in the North East, East Midlands, West Midlands and South Central areas of England, and the setting was primary care. The intervention was also delivered in the community, and the reason we decided to do that was because we didn't want the intervention to be in a hospital setting as per se. We wanted it to be outside of where patients may be used to attending various appointments. And this is what came across from our patient and public involvement meetings. They particularly said they valued a program which was in the community. So the inclusion criteria, the trial included adults over 18 years, using opioids for chronic non-malignant pain, and reported using strong opioids for at least 3 months and on most days of the preceding month. So what's quite key there is that we used strong opioids, but this was defined at the time that the study was started, and using the BNF, I think it was 2016 or 2017, that we used that definition. And then we had our exclusion criteria there, and we excluded people with chronic headaches. Again, this is a different type of population, and actually at the time of this study, we also were running a program grant specifically looking at the management of chronic headaches. So just for interest, these are the list of opioids that were included. So the patients were on any of these, and again, that was based on the BNF at the time. And our study outcomes were at 4, 8, and 12 months, with 12 months being the primary endpoint. So we had 2 primary outcome measures, which were activities of daily living, self-reported, and opioid use as well. And this was the proportion of people reporting no opioid use over the sort of previous 4 weeks. So the target difference that we were actually aiming for pain interference was 3.5. So just bear that in mind when we talk about the results in a bit. And then we also had a whole list of self-reported secondary outcomes: pain severity, pain self-efficacy, sleep, and opioid withdrawal. So the actual intervention. So as I said, as a health psychologist, this is pretty much what we do all the time. So we really embedded a behavioral change framework. So when you think about behavior change, the behavior we're trying to change is helping patients to actually make that decision and stop opioids. And we use the COM-B framework, which includes capability, motivation, and opportunity, which is a well-known framework within the behavior change world. It's actually pinned on a behavior change wheel, which encompasses 19 different frameworks of behavior change. So if you're not too familiar with behavior change, something like this, or the behavior change wheel, has swept up 19 different frameworks and really pulled out the core elements that will help people make that decision to change their behavior. So in terms of capability, so this is really the individual's psychological and physical ability to engage with opioid tapering. So in particular, thinking about their psychological capability, can they engage with the necessary thought processes? We know patients are going to be on various different levels of opioids. They may have difficulty in concentrating. They may feel a bit overwhelmed. So how can we help them during that program to actually navigate through the information that we're giving them? It's not just about bombarding them with information. Cognitive functioning, again, in an intervention, even a consultation, if someone is on various levels of opioids, they may have some challenges with remembering what they've been told. So again, we were thinking in our intervention, how can we help patients process information and reflect on it? And what we designed were handouts. We had DVDs that they could go away and view with their family members, and actually really start to reflect on what they were taught in our program. Executive functioning is the capacity to plan and think. So during our intervention, we had group sessions and one-to-one. And the one-to-one consultation is that processing. They can actually start to think, should I be tapering my opioids? Have I got the right skills to do it? Okay, and motivation. There's 2 types of motivation: reflective processes and automatic processes. And again, this is really much helping patients to evaluate why they want to taper in the first place, tapping into their beliefs, their attitudes. Do they actually feel that the risks outweigh the benefits? And also allowing them to acknowledge their emotions during the tapering process, because they may feel anxiety, they may feel low mood. But that will happen during the program of tapering. So as a clinician, it's working with the patients to navigate through those emotions rather than seeing those emotions as a big barrier or block to further tapering. And then opportunity, which is the final component of that behavior change, is really factors to make the opioid tapering possible. So thinking about where your interventions are going to be, thinking about access, who's going to deliver the tapering program, and will they have support themselves as well as supporting the patients. So the structure of our program was, we had 3 full-day group sessions with 2 face-to-face consultations and 2 telephone consultations. So patients would come to a group session on week 1 and week 2, and then they'll have a one-to-one consultation followed by the final group session, and then the rest were one-to-one consultations. And the actual intervention was delivered by nurses, so we trained nurses to be able to deliver the group sessions and the one-to-one sessions as well. But most importantly, we also trained lay facilitators. So these are people who have experience of chronic pain and also opioid tapering, and they were involved in delivering the group sessions. So the types of information that we used in the program were opioid education, so allowing patients to understand what chronic pain is, why they were prescribed opioids in the first place, and then really starting to understand what the possible side effects are of opioids as well. What we did find during when we were designing the intervention with our patient and public involvement is a lot of input was put into the types of information we should be giving, especially at the beginning of the program. And that included what side effects came with being on long-term opioid use, because a lot of patients didn't actually realize that they were living with various side effects, such as severe constipation, low mood. Quite typically, we were hearing phrases like, well, I've just been zombified for the last 2 or 3 years of my life, and I didn't think, could it be down to the opioids I've been using? So it was really important that we reloaded the beginning of the intervention with the opioid education. We also developed an opioid tapering app. So this was used in the one-to-one consultation, and the nurses would literally plug in what opioids the patient was currently taking, and then the app generated the tapering plan. So it was a 10% reduction until 30% was released, and then until 30% was reached, and then 10% of that 30% until complete cessation. It's important to just say here that the tapering could be paused. So although the plan was generated, it was always clinical decision that overruled the actual app. So depending on what the patient was saying during the tapering process, it was okay to adjust, slow down if needed. So that was the intervention, and the control intervention was best usual care, which was a booklet, My Opioid Manager, which is quite a comprehensive booklet designed by our colleagues in Toronto. And so because at the time there was absolutely nothing else that we could offer our patients, rather than giving them nothing, we gave this booklet plus a relaxation CD as well. And those in the intervention group also got the My Opioid Manager. So that's like I said, the paper has been published, but that's a quick overview of what the intervention was. So I think the main just key takeaway points of that is that the intervention included group sessions plus one-to-one support. It was delivered by a nurse and a lay facilitator, and they were trained over 3 days to be able to deliver this program. So that's the key takeaway of the intervention. So what did we find? Did this actually work? So in terms of recruitment, we screened just under 2 million patients from 200 general practices. And going through all the screening process, eligibility and so on, we actually ended up recruiting 608 into the trial, and 608 people were randomized either into the intervention or control Currently, this trial is the largest of its kind in the UK and globally for a behavioural type intervention on opioid tapering. The mean age was 61 years, 60% were female, and 97% were white British. In terms of baseline measures, just to give you an idea of the types of people we had in our program, you've got the opioid banding. In terms of pain interference and pain intensity, it was pretty much similar in both our intervention and our control groups as well. Most of our patients had been on opioids for more than 5 years and had been living with pain for more than 5 years as well. And the types of pain that were reported, typically, like again, as we would probably expect to see in this population, musculoskeletal, so lower back pain was quite high across both groups. In terms of intervention, we delivered 35 groups. Now, that might not sound like a lot, but I can honestly tell you that these complex interventions are very complex to deliver as well. Because when you recruit patient participants into a trial, you have to pool them, and then you have to obviously make sure everything is aligned. So that means you've got your facilitators that are going to deliver on that day, your participants, you're giving them the date of the days and the one-to-one consultation. So there was a huge amount of work that went into delivering 35 actual intervention groups. 68% attended group session 1, 53% achieved minimum adherence. And again, it's quite typical of what we would see in pain management programs. Minimum adherence was attending at least one group day and at least one face-to-face session. And then full adherence was all 3 group days, 1 face-to-face and 1 telephone adherence as well. But we did case analysis, and we've adjusted for all of this in our analysis. Total follow-up rate was 72% and withdrawals were 16%. So what did we find? So in terms of pain interference, remember this was self-reported at 4, 8 and 12 months, and the target difference we were aiming for was 3.5. We found no significant difference between the intervention group and the control groups. But what we didn't do is make their pain worse. So although we didn't have an impact in terms of between the groups, the trends showed that the pain didn't get worse either. So we didn't make their pain worse, but what about their opioid cessation or stopping the opioids? We did make a difference there. So the odds ratio are presented with the confidence intervals at 4, 8 and 12 months for the iWatch intervention and the control. So 29% of our participants in the iWatch intervention had completely stopped at 12 months compared to 7% in the control intervention. So the odds ratio is showing that you're 5 times more likely to stop your opioids for those that went through the iWatch intervention. And you can see there actually we made a difference at 4 and 8 months as well. Clinically, our co-investigators who were keen that we also presented the 50% reduction as well. So not only those that were able to stop completely at 12 months, but those that also were able to reduce at least by 50%. And as you can see there, we also made a difference with 57% in the intervention reducing by 50% compared to 27% in the control. So really, we have shown that the iWatch intervention did help participants to reduce their opioids. So this graph is just presenting, so the blue lines show the intervention and usual care for pain interference, and you can see we didn't make a difference between the two, but as I said, the trend is showing we didn't increase their pain interference, but the biggest difference you can see there is in the intervention and usual care arm for opioid cessation. So not only were we able to, opioid use, so not only were we able to actually help people reduce, but the trend continued over 4, 8 and 12 months. So secondary outcomes. We didn't make a difference on the secondary outcomes at 8 and 12 months, but at 4 months we did see a difference in pain self-efficacy, in HADS depression, and some quality of life. So again, very sort of typical of what you would see in a brief intervention is when that's finished, people feel a bit more empowered then. So we would expect to see that pain self-efficacy increase at that point. The fact that the fact that people were able to sustain and stay off their opioids at 12 months does suggest that part of that self-efficacy has, sort of sustained through. But again, in terms of what we were trying to achieve and motivate to actually get patients to make that decision to taper, I think, that empowering and pain self-efficacy score is important. I think we can't underestimate, that's a huge decision to make because a lot of these patients had been on opioids for a long time and we were not offering them anything else. There was no substitute. There was no other medication. It was pretty much, we want to help you get off and here's a non-pharmacological intervention that we're going to help you with. Saying that, I just think that's also a very, I'm not being biased here, but I think that is a big success of the trial, is the fact that we actually recruited 608 people without offering them anything else in terms of their intervention whilst reducing them off their opioids. So we did also, so all of the serious adverse events are in our paper which is published, and again there was nothing really of major concern. There were 5 deaths reported, but I can say that all of the deaths were not related to the intervention. So the quantitative results, the clinical results were very promising, showing that the iWatch definitely has got active ingredients in there that are helping people to make that decision to taper off their opioids. We also did a qualitative process evaluation alongside this, and again, that paper's also been published in the BMJ Open. And I'm just going to briefly sort of just pick out some of the themes that have come up. So this may help when we're thinking about having those discussions with patients. So first of all, patients reported that in order to make that decision to taper, they had to feel it was the right time for them. And that right time incorporated other things that were happening in their lives. So whether they had other appointments, other perhaps plans, invasive treatments, well, hopefully not, but they might have had other appointments, other treatment plans, other things actually not even related to their health condition going on at that time. So if they felt they were not able to really focus on the opioid tapering, they were less likely to engage in that program. Living with the complex life with chronic pain. So a lot of our patients in the qualitative paper also commented on the fact that they're not only living with pain, it's dealing with everything else that comes with that, which could be the low mood, anxiety, the stress, other health complications, and that was affecting their decisions. So it kind of ties in when they feel it's the right time to taper. Needing support. So a lot of people said they may have thought about tapering, but the issue or the challenge they had was, where do they get that support from? Because quite often, perhaps the clinician didn't always approach the subject of opioid tapering, and maybe prescriptions were given, or maybe the patient just didn't feel confident to be able to bring up those discussions during the consultation. So needing the support was quite a big component. And then the group effect. So in the iWatch intervention, we combined group sessions with one-to-one consultations. And the one-to-one was very good in terms of tailoring that tapering, but a lot of patients commented on the group effect. So being able to be in the room with other people, to share experiences, and to connect perhaps even with a lay facilitator who's actually been through tapering themselves. So iWatch participants gave, again, this is from our qualitative work, participants an informed choice if, how, and when to taper. It was not a forced tapering. I think I really have to stress that because the shared decision-making really happened from day one of the program. You're informing, you're educating, you're having those one-to-one consultations. We did train our nurses on motivational interviewing as well, so they were able to really help patients. I keep saying patients and participants. So they can help participants set their realistic goals and assess their own attitudes and beliefs. Education about opioids. iWatch gave participants skills in pain self-management. iWatch gave participants motivation through support, so the group session with the peers, and confidence in a tailored reduction program. And that really has come out quite strongly in our qualitative work. So just in terms of the opioid discontinuation systematic review that I showed earlier with those 2 studies, we have done our sort of own analysis, and we've included our results. And you can see that the pain self-management programs are still very much favoured in terms of effectiveness. And I think this is really promising, because we need to start building this evidence base of where do we go from here? What kind of programs are, and it's not a one-size-fits-all, absolutely it's not. But, you know, we've got promising starts and big trials, which are now, well, big trial which is now showing that a behavioural type intervention can really support people through. So in terms of where do you go from here, what do you do? So clinical skills to consider, really start thinking, you know, listening to the patient, think about the therapeutic relationship, because obviously this involved group and one-to-one sessions, but the conversation has to start somewhere. Reassure the patient, so at each point of the tapering, this is what happened during the one-to-one. Every time a participant came in and said, oh, I'm not sure, I feel a bit nervous, that reassurance is important to keep them motivated. Share some successful stories. If you have got a case studies in your clinic of anyone that has tapered, or even from, you know, research, if there are stories that you can share, people are more likely to say, I connect with that. So think about the types of resources that you can pull into your own clinics. So one approach doesn't fit all, and we're very much aware of that. You know, the iWatch at the moment is 100%, we think it's a great trial. It's, like I said, one of the largest at the moment, but this is group interventions and one-to-one support, and that's not going to fit for everybody. So we need to now start getting other types of interventions as well. There's room for plenty more. And reflect on your own goals and expectations. How much do you know about opioid tapering? How much are you invested as clinicians? I mean, the fact that you're in this session today hopefully is a good indication that you are interested, but really think about that, because your own judgments are going to play a big part, consciously and subconsciously, in how you are prescribing and helping your patients make that decision to come off their opioids. Have your own toolbox ready. So again, educational parts, and part of iWatches, we have this whole educational program, which I'll talk about in a minute in terms of rolling that out. And consider your approach and why. So I read a paper, I think, the other day, and it was quite interesting, saying that those that have a full clinic or perhaps running behind are 30% more likely to prescribe. So just think about that next time when you're with your patient. How busy have you been today? And how full is your clinic list? So, you know, really think about that, having those conversations. So the iWatch intervention worked. That's the picture of the facilitator manual. The number needed to treat was around between 4 and 5. There was no increase in pain and pain-related disability. And now really we want to see, where do we go from here? So I appreciate definitely that some of you may be thinking, this is great, brilliant that you spent 10 years of your life doing this, but how does this affect our clinic? How do we get this into our busy days? How do we fund something like this? So we are still doing our cost effectiveness analysis, and that should hopefully be published sometime this year. So we're very much aware that that's going to be a part of the picture as well. But I don't want you to go away thinking that iWatch is something that's completely out of reach for us. We have demonstrated here behavioural components, active ingredients that are useful in helping people make the decision to taper from their opioids, to even consider their own barriers and challenges, and most importantly, to support them through it, both from the clinician point of view and the participant or the patient. And these are the skills that we need to get out. So we know group sessions and one-to-one sessions work. And it may be that in the future we need to think about online. Maybe I've been blown away by all the AI talks. So the future will probably have incorporation of AI into these sort of programs. But like I said, I'm excited by this because, especially here now, we've got a trial that we can build on. And I know there's other great work that's happening across the country which will be hopefully published this year as well. So why have I got this picture of this beautiful lady on our screen? So this is Dr. Dania Dharmesh, and she is an assistant professor with us at the university who's joined our team and is now helping in sort of the implementation side. So where do we go from here? And the reason I've got Dania's picture is she's also with us for the next few days. So either if you see her and you want to talk anything more about implementation, please do stop her. I'm around for the next 2 days. Martin Underwood is also around, so we want to have discussions now. Where do we go from here? We are working with the NHS England Medicine Safety Improvement Programme. We've got a couple of integrated care boards in the North East and South West London, and we are now looking at a few clinics that are going to actually start putting this into the real world. So that's exciting for us. It's also very scary because we're used to so much control over a research project, and now it's so implementation science is something I'm definitely learning a lot about. But yeah, so I'm excited for the future, and I really appreciate you coming here. And like I said, if there's anything you take away today, it's that the iWatch intervention is a complex intervention. It's got health psychology, behavior change. It worked. It helped people come off their opioids. We know long-term opioid use is not good. We're not saying it's not good for everybody. Small doses may be good for some people, but the evidence showing it's not good. Post-operatively, we know the majority of patients are staying on their opioids after 90 days. They're being discharged into primary care, and that's it. They're being lost in the system, and the prescribing is just, that cycle is continuing. And I think we've got the responsibility, to break that cycle. That's co-investigators, so thank you to all of the team, and finally, thank you. Thank you so much.
Thank you so much, Harbinder.
Thank you.
Shall we go for any questions? Are there any questions?
Hey.
Thank you. Lisa Roberts from Southampton. And first of all, congratulations on the meticulous trial design and an amazing programme. I think one of the things I was really struck by was that you had 97% of people in the trial who were white, British.
Yes, yeah.
And I just wondered, do you think that's because people from the communities that we seldom hear from are either not being prescribed the drugs, not taking them, or not wanting to be in the trial? And I just wondered, going forward, if you have any plans to be able to reach out to those communities. Thank you.
Yeah, no, that's a really good question, and I think it is the latter of what you said. So we need to be doing more in terms of accessing these communities, and I think we're running other trials in other sort of conditions, and what we're learning now actually is engaging with the community leaders. So going in, having these talks and investing that time first. And I think that's something that we will do with iWatch as well. And in terms of the materials, making it more accessible too. And that's all the online materials as well as the written.
Crystal Matry, University of Sheffield. I had a similar question in terms of that kind of diversity, particularly around your PPI groups as well. So how did you ensure that you got that kind of diverse involvement when you were designing the trial initially? And did you have any groups which were within those kind of the regions that you showed at the beginning with the higher opioid use?
Yeah, that's a really good point. So actually, the PPI groups that we engaged with were from the North East, so they were at South Tees Hospital, and they were already an established PPI group that would meet to discuss various trials, and particularly then an advert went out for anyone interested sort of in chronic pain and the opioid use. And there were quite a few people that came. I can't remember the exact numbers, but because it was an established group already, we didn't ourselves actively go out to recruit and make sure of that diversity. But that is a really good point. And I think, again, moving forward, as researchers, we need to make sure we are doing that in our PPI groups, because that's what we're then missing in terms of adaptations.
And I was wondering as well, so because you had kind of the 3 full-day workshops, did you find that there was any issues with those from those more socially deprived areas that might have more issues of getting time off work and paid time off work particularly to actually attend those kind of full-day workshops?
Yeah, so again, I mean, I guess the fact that we were able to recruit in the Northeast anyway, once they were into the trial, they were fully aware of where the intervention was being held and being able to actually get that time off to attend. So the ones that probably didn't go in are the ones that actually couldn't attend anyway. And again, that's very typical, isn't it, in sort of the real world with our pain management programs. Once they're in, if people miss a program, they may have to miss the next 2 because they can't make that. But again, you know, moving forward, if we're looking at more online type interventions, could that be something that could maybe reduce the amount of people that maybe can't attend physically? So these are all things, I think, for future development. Thank you.
Thank you. Final question.
I'm Partha Basu from Leicester. I'm a spine surgeon. Did you look at this? Because my understanding is that when we see patients in secondary care or tertiary care, we don't much prescribe opiates for back pain. That's not the practice. Most of these come prescribed by their primary care clinicians. Was that the finding for you? And if that's the case, is it not that cohort of clinicians who we probably need to target to stem the tide?
Are there any primary care physicians here? I'm happy to be the middle person. We recruited from primary care, so we didn't go into sort of where that prescription came from. These are from GP practices, screened and got them in. Very interesting question. I can definitely tell you that I find I have these conversations quite a lot between my colleagues in secondary care and my colleagues in primary care. I think there has to be a way of, you know, meeting halfway. I don't know what the right term is here.
I don't mean to be confrontational or anything. This is just a finding that we see. Patients come prescribed with the opiates. We don't prescribe them. I'd often try and dissuade, but that's a different issue.
Yes. So by the time they come to you, they're already...
My point, it's not one against the other. It's just we're working together.
Yeah.
But if that's where most of the prescriptions come from, should we not be targeting that to change behavior there from the prescribers, not the patients or the participants?
Yeah, so this program was in primary care. So I guess we train nurses to deliver the program. Now, there is a whole other area of work around education for our clinicians on prescribing. You're absolutely right. That was outside the scope of this trial. We did want to do that, and we were told we were a bit too ambitious. So we've parked that for now. But you're absolutely right, because that is another whole stream of work is around the education for prescribers across, I think, everywhere.
Thank you.
Yeah. Thank you.
Thank you so much.
Thank you.
Everyone.